Due to physiological changes that occur after menopause, there are certain risk factors for women for cardiovascular disease. Women who are smokers or who have impaired glucose tolerance or they have familial hyperlipidemia or hypertension are more prone for cardiovascular diseases. The risk factors of osteoporosis are again family history of osteoporosis, women above 65 years, women whose diet is deficient in calcium and vitamin D, those who are having more of coffee, smoking or alcohol, those who are having sedentary habits, they don't have any exercise pattern every day, or those who are on medication like heparin or corticosteroids, or suffering for some diseases like hyperparathyroidism, they are also more prone for osteoporosis. So, diagnosis of menopause is retrospective after the 12 months of stoppage of menstrual cycle without any other pathology. And in these women, FSH is elevated. Now, having discussed the symptoms and problems of menopause, we should know how to treat them, how to manage the women who have various symptoms of menopause. There is a non-hormonal treatment and hormonal treatments. In the non-hormonal treatment, lifestyle modification is very important. The women should be encouraged to maintain or include physical activity every day. They should do some exercise like walking or some weight bearing exercises. It's very important, and they should maintain their weight in the proper BMI. They should not be obese. The lifestyle, they should reduce the coffee intake, smoking and alcohol intake. Their diet should be nutritious and it should contain all the components of nutrition. And supplementary calcium is very important. Generally, daily intake of 1 to 1.5 grams of calcium is important to reduce osteoporosis and fracture, basically even to reduce bone loss, which will promote the chances of fracture for them. In the diet, there should be adequate amount of protein and calcium apart from other minerals. Exercise is very important, as I already discussed, and vitamin D supplement is also important because in this age group often they are having deficiency of vitamin D. So vitamin D can be given daily or it can be given once in a year, dosage of about 6 lakh units divided dosage, or it can be given by injection. Then there are certain other drugs like calcitonin, which will inhibit the bone resorptions because it will inhibit osteoclasts. The osteoclasts are one which will cause bone resorption. So this can be given with calcium and vitamin D. Another thing is biphosphonates. This also improves the bone density, and it is generally given in older women, maybe above 65 years, and monitor the bone density. The drug is stopped if she develops any severe pain. The other things which can be given is Soames, that is selective estrogen receptor modulator. These are the drugs like raloxifene. They show to increase the bone mineral density. They reduce LDL, then they improve HDL level. So this will reduce the risk of breast cancer or endometrial cancer in these women. But they don't have any effect on hot flashes. So for hot flashes, there are other drugs which can be given. These drugs are, one is clonidine or paroxetine and gabapentin. These are the different drugs which can be given. Now, clonidine is an alpha adrenergic agonist and reduces the severity and duration of hot flashes and helps the woman to have undisturbed sleep. This can be given when there is estrogen is contraindicated. We can give these other drugs. This paroxetine is selective serotonin reuptake inhibitor, and gabapentin is analog of gamma aminobutyric acid. You can also advise phytoestrogen that contains isoflavone in certain food items that can be advised. Its effect is controversial, but claims are there that it reduces the osteoporosis. Soy protein also comes in the same. It also is supposed to reduce vasomotor symptoms. And vitamin E is a drug which also reduces hot flashes. Now we come to hormonal therapy. What are the indications for hormonal therapy? They are to relieve the menopausal symptoms, relieve the even vasomotor symptoms. They can prevent osteoporosis. And this is to improve the quality of life of the menopausal woman. What are the contraindications? Contraindications of the hormone therapy are: any woman with a known history of breast cancer, we should not give hormonal therapy. A woman with undiagnosed genital tract bleeding or estrogen depending neoplasm or history of DVT. If there is a venous thromboembolism, then we should not give estrogen because that can increase the problem of deep venous thrombosis and it can lead to embolism and stroke or cardiac problem. A woman with active liver disease or a woman with jaundice, we should not give any hormones. Even for that matter, gallbladder disease. If the woman is suffering for gallbladder disease, we should not give. History of endometriosis also is a contraindication for hormone therapy. Now, what are the risks of hormone therapy? Because we don't keep continuing the hormone therapy. Hormone therapy is given for minimum time and at the lowest dosage which is effective. We should not give it for a longer time or at a higher dose. So we give it for the lowest effective dose for a shortest period of time, because hormone therapy carries the risk of endometrial cancer, breast cancer, especially when it is unopposed estrogen. That's why whenever we give hormone therapy in a woman who is not hysterectomized, we combine it with progesterone. And the another risk is venous thromboembolic disease. That's why history of DVT we don't advise estrogen. Then woman who is having coronary heart disease history also we don't give hormones. Women who are having problem with the lipid metabolism, don't give hormones. Then next, whenever hormones are given, we should always monitor the patient before and during hormone therapy. Now, how do we monitor the patient? We should do the physical examination, including pelvic examination, before the start of the hormone therapy. It is also advisable to do one scanning to rule out any ovarian mass. We should see that the ovary is normal for the menopausal woman, its size has decreased. and it is not normal size, which is for the reproductive age group, or increase. It's very important to rule out any ovarian pathology. This can be done by PV examination, and we can also do ultrasound to have one basic picture before we start any hormone therapy. Blood pressure recording also should be done before starting and also during the HRT therapy, because we are giving estrogen. Breast examination is mandatory before we start any hormone therapy, because if there is any mass in the breast, hormone therapy is strictly contraindicated, and we may need to do mammography to see the texture of the breast for the pathologies which may not be seen or which may not be diagnosed on clinical examination. Cervical cytology is also done for the same reason, to rule out any atypia in the cytology, because atypical cells or pre-malignant conditions is again contraindication for hormone therapy. Pelvic ultrasound is also done to measure the endometrial thickness, because postmenopausal women, the endometrial thickness is not more than 4 millimeters. So if it is thick endometrium, then we will suspect there may be endometrial hyperplasia or maybe endometrial cancer, and this patient needs further investigation, the endometrial sampling, to rule out endometrial cancer. So sonography is done to know endometrial thickness as well as to know the condition of the ovaries. Patient with any irregular bleeding, again we have to rule out endometrial hyperplasia or cancer or any other pathology, and we cannot start HRT unless we are sure that there is no the abnormal bleeding is not because of any cancer. The ideal serum level to prevent all these hot flashes will be about 100 picogram per ml. As we have seen in postmenopausal women, finally estradiol is less than 100 picogram per ml. Now there are various regimes for this hormone therapy. Mainly estrogens are used. Oral estrogen, conjugated equine estrogen is available. Commonly it is available in 0.625 milligrams, which is given daily for the women who have had hysterectomy. Often we give this to women who undergo hysterectomy for couple of months if she develops post-surgical menopausal symptoms. A woman who is having uterus, we should give estrogen and cyclical progesterone. So estrogen is given for 25 days and progesterone is added in the last 12 to 14 days. There are different approaches to give these hormones. One I told is oral estrogen therapy, which is given. Oral estrogen and progesterone given. Sometimes we give estrogen and progesterone continuously so that there is no endometrial hyperplasia. But in this kind of continuous, patient may develop irregular bleeding, which may cause a lot of concern to the patient. Then you can also give transdermal administration, which contains 3.2 milligrams of estrogen, and it will give every day 50 micrograms. It will deliver that in the blood. So this transdermal administration can be applied above the waist level, and it has to be changed twice a week. The drug used here is 17 beta estradiol. Now there are certain subdermal patches also you can implant. The implants are inserted under anesthesia generally. Local anesthesia can be used. Again 17 beta estradiol implants of 25 milligrams, 50 or 100 milligrams available depending on the patient's severity of the symptoms. We will decide how much to put, which implant to choose, and it can be used for 6 months, and then it can be changed if required. It can be changed later on. Then there is percutaneous estrogen gel. It's a 1 gram applicator of gel which will give 1 milligram of estradiol daily. This is applied to the skin on the anterior abdomen wall or on the thighs. For women who are having vaginal atrophy and who do not want to take oral hormones, some women don't like to take hormones orally, we can advise them vaginal cream to be applied locally. This vaginal cream is also quite effective for the atrophic vaginitis, and it gives a good improvement of the urinary frequency or urinary urgency. And also these women suffer from recurrent infection, often with candida infection if they are diabetic. So their diabetes should be controlled, and you can allow this vaginal cream which will control the repeated infection in these women. Then progesterone can be given to women who are having history of breast carcinoma, because you cannot use estrogen in them. So any women with having history of breast carcinoma or endometrial carcinoma, we can advise medroxyprogesterone acetate 2.5 to 5 milligrams daily. It will prevent osteoporosis, and it will also improve the hot flashes. Then there is a IUCD which can be used, LNG-IUS or levonorgestrel intrauterine system. This is often used for women who are having DUB, perimenopausal DUB without any endometrial hyperplasia. In these women, for the heavy bleeding, we use this intrauterine device, but it can be used even for the postmenopausal women. This will release daily 10 milligrams of levonorgestrel, and the advantage is that it prevents endometrial hyperplasia and endometrial cancer, because it is progesterone and not estrogen. And because it is an intrauterine device, it doesn't have any systemic side effects. And in perimenopausal women, it can also be advantageous for them. The added benefit is it can be used as a contraception method also. Then there is another drug, tribolones. It's a steroid. It's a steroid which has weakly estrogenic, and also it has progestogenic and androgenic properties. This also can be used 2.0 milligram daily for the treatment of hot flashes and vaginal atrophy. It prevents osteoporosis. Sometimes we also use testosterone because if they are having hypoactive sexual desire, testosterone can be used. It improves the mood, it improves the bone and muscle mass also, and quality of life. Parathyroid hormones are also used, given by injection, to prevent osteoporosis and fracture, because parathyroid hormone increases the osteoblast cells, thus it improves the health of the bones. A low dose 20 microgram per day is given for anabolic effect of the parathormone. Now, what is the duration of hormonal therapy? Hormonal therapy, as I said, you should give it for as short period as possible, depending on the benefits versus risk ratio, and it is to be individualized, and depending on the progress, depending on the effect of the hormone therapy, we can decide. But very important is you should not abruptly withdraw the exogenous estrogen because it may cause the return of her symptoms, especially hot flashes. Tapering of the estrogen pills are important, so slowly it has to be reduced. If she is taking daily, maybe you can make it alternate day, and then after couple of months you can make it, or after 1 month you can make it 1 in 3 days, and then you can stop this estrogen. It is sometimes in a short tapering, you can taper it in 6 weeks, and then sometimes you use a slow taper which will be over 2 months or so.